Hello, everyone, and welcome to today's AC Forum webinar on the topic of DOACs and obesity in 2021. I'm going to give it a few minutes here to allow, or a few seconds here to allow more folks to log in before we get started, but we appreciate your attendance at this. This is a very hot topic that's been strongly debated over the last 5-6 years. So excited to have the opportunity to speak to this with real experts. And I see we have a number of folks still logging on. So why don't we go ahead and go to the next slide, please? So this webinar will be moderated by myself, Salt Lake City, Utah, from Deb Siegal at University of Ottawa in Canada, and by Andrea Van Beek in Visalia Medical Center in California. We have the honor of actually having two of the authors of the paper that will be highlighted, Karlyn Martin at Northwestern University, and Stephan Moll at University of North Carolina. Next slide. And if you haven't heard Stephan Moll's name because of his thrombosis expertise, his dashing good looks, or the fact that he's an all-around nice guy, you may have heard it when he made national news as the first doctor to treat a blood clot in space. So congratulations, Stephan. That was really interesting to see that come across. Next slide. These are the disclosures of the moderators and speakers, some of which relate to the use of anticoagulants that will be discussed today. And next slide. And before we get started with today's talk, just want to let you know, one of the more popular rapid resources on the AC Forum website has been this DOAC use in the setting of bariatric surgery and feeding tubes. And because the new ISTH guidance that we're going to be discussing addresses bariatric surgery, we wanted to let you know that this has been updated, hot off the press. And you see the link here to pull down this one-page rapid resource. So you can use that. And at this point, I'm going to turn it over to our speaker and the author of the paper, Karlyn. Karlyn, take it away.
All right, thank you. Thanks everybody for joining today. So as Arthur mentioned, we are going to talk about our recent publication guidance for the use of direct oral anticoagulants in patients with obesity for the treatment of venous thromboembolism. So first, I want to touch on the impact of obesity worldwide. I'm sure all of you are aware, but obesity is on the rise. About 13% of the world's population are obese. According to the World Health Organization, in 2016, over 1.9 billion adults were overweight, as defined by a BMI greater than 25, 650 million of whom were obese with a BMI of greater than 30. On the right here, you can see the impact specifically in the United States. This represents the prevalence of obesity in each state. So every state has an obesity prevalence of more than 20%. And in the dark blue, you can see a significant number have a prevalence of obesity of greater than 1/3 of their population. So this is certainly a problem that all of us will face. And since our patients with both venous thromboembolism and atrial fibrillation, many of them will be obese, it is something that we will need to make decisions on. So in 2016, the International Society on Thrombosis and Hemostasis put out a guidance statement about the use of direct oral anticoagulants in patients with obesity. At that time, we recommended appropriate standard dosing of direct oral anticoagulants, which I will refer to as DOACs, in patients with a BMI of less than 40 and weight of less than 120 kilograms. At the time, we suggested not to use DOACs in patients with BMI above 40 or weight greater than 120 kilos. And if DOACs were used in patients above those thresholds, we recommended to check a drug-specific peak and trough level to ensure that levels fell within expected ranges. The guidance statements at the time were based on lack of clinical data. So the phase 3 trials of DOACs in for VTE and AFib did not include very many obese patients and at the time did not publish the data specifically for obese patients. And so because of this lack of clinical data, along with some of the PK/PD changes that were seen for the DOACs in high weight, these recommendations were made. At the time, we did encourage that more studies to be undertaken to better understand the safety and efficacy of DOACs in patients with obesity. Since that time, over the past 5 years, there have been numerous studies published with data published about the DOACs in both the AFib and VTE population. I want to point out that today's paper and today's discussion will be limited to VTE, the VTE population, which is what we focused on in the updated guidance statement. So because of the studies that have been published since 2016, the authors of that original guidance paper got together and formulated updated guidance, which was published this year. So we did a literature search to identify studies published with VTE treatment and DOACs and obesity, and then did video conferences to discuss our consensus recommendations, which were then published. Here, this table shows the study categories that we looked at. The studies were both phase 3 studies, post hoc analysis of the randomized controlled trials, both the individual DOACs as well as meta-analysis of the pooled DOACs in the phase 3 studies, which are listed on the left. And then on the right are the phase 4 studies, which are observational studies, primarily retrospective, but also some prospective and meta-analyses. The studies looked either or presented their analysis either individually, individual DOACs, or pooled the DOAC and compared it to the vitamin K antagonist. The other important study design to think about is that some of the studies look at a given drug across weight categories. So how do outcomes compare with apixaban with a BMI of 25 versus 30 versus 40, whereas others compared the DOAC versus vitamin K antagonist at a given weight category. So for example, apixaban versus vitamin K antagonist at a BMI of 40. And so this table summarizes the findings, but in the next few slides, I will highlight some of the studies. So first, this is looking at rivaroxaban and the post hoc analysis of the Einstein DBT and PE studies. These authors analyzed the primary outcome, which is recurrent VTE, as well as major bleeding by weight categories, both BMI and weight. So here I've pulled out the findings for the highest weight BMI, which in this study was greater than or equal to 35. They divided it into both the whole study period, which is 12 months, as well as the first 21 days. And you can see here that the hazards ratio are similar for recurrent VTE with confidence intervals that cross 1, so non-significant and no significant difference in recurrent VTE between the rivaroxaban arm and the VKA arm. Similarly, no significant change in the rates of major bleeding with rivaroxaban compared with vitamin K antagonists. As I mentioned, the authors also looked by weight category. I pulled out the data for the highest weight category, which in this study was 120 to 140 kilograms. And again, they did not see a difference in VTE recurrence, although limited by small numbers of outcomes. Next, I want to highlight data from the post hoc analysis of the Amplify study for apixaban. I want to note that this was published after our paper literature review. So we did not review this paper in our guidance statement, and we did not include it in our conclusions, but wanted to highlight it today. So they similarly found similar rates of recurrent VTE or VTE-related death. And actually, sorry, here we see this in the forest plot and the increasing BMI at the bottom of this table, and you can see no significant difference in recurrence rate. And here are the plots for major bleeding. Again, the obese patients fall at the bottom of the graph, and no significant difference in recurrence rate, although a trend towards lower rates of major bleeding. And this held similar across BMI and weight categories. This was a meta-analysis of the phase 3 randomized trials of VTE and DOAC. This included over 5,000 patients in the high body weight groups, which depended on an individual study. But again, in the high body weight groups, there was no significant difference in VTE and VT-related deaths between the DOAC arm and the VKA arm. And similarly, rates of major bleeding were not significantly different between the DOAC and VKA arms. We, in the manuscript, we also reviewed the observational studies for a given, for each individual drug. Given time limitations, I'm not going to go through all of them today, but here wanted to show a sample of observational studies that pooled the DOACs. So they combined the data for all of the DOACs and in their comparison. And you can see here across the board, whether it is a prospective registry study, prospective observational, or retrospective study, all of the studies found similar rates of primary outcome, recurrent VTE, as well as similar rates of major bleeding in the DOAC arm compared with the VKA. So no signals to suggest that there are worse outcomes in the obese patients treated with DOACs. And here is a meta-analysis of these observational studies. This publication included 6,500 patients, although notably a large majority of the patients came from one study that used administrative claims data, so defined obesity based on ICD coding rather than BMI. But for these patients with obesity, included 5 observational studies. Again, we did not see a significant difference in rate of recurrent VTE with DOACs, and there was a trend towards reduced risk of major bleeding, which is shown on the bottom panel here. So in the publication, we also looked at and reviewed updated publications with DOAC levels and pharmacokinetics. Overall, there were not significant changes in drug levels in obese patients compared with normal weight. I did not review them here, but they are available in our publication as well. Overall, we did not find utility in monitoring drug levels in these patients primarily because of the lack of clinical outcome data correlated with drug levels. So here I summarized the clinical data again, and you can see there are both phase 3 and phase 4 studies, and across the board we see similar outcomes with the DOACs compared with the VKA in either type of study design. There is certainly there have been more studies published with rivaroxaban, as well as those that pool the DOACs together. But some data that exists for apixaban, unfortunately, there is not data looking at dabigatran or edoxaban in patients with obesity, so difficult to make conclusions for those drugs. So our conclusions were that when compared individually to vitamin K antagonists, rivaroxaban and apixaban have at least similar efficacy and safety in patients with obesity. The studies that pool DOACs similarly have similar rates of efficacy and safety across weight categories, but there were no studies that limited the analysis to betrixaban, dabigatran, or edoxaban individually for treatment of VTE. We also reviewed data for bariatric surgery and DOACs. This is our interpretation of where the DOACs are absorbed and how different bariatric procedures may impact the absorption of these drugs. Our conclusion is that we recommended not to use DOACs in the acute setting after bariatric surgery, which we defined as a month, because of concerns of reduced absorption and other impact of PO intake, and instead to use parenteral agent after 4 weeks. We could consider switching over to a DOAC or vitamin K antagonist, but at that point recommended checking a drug level to ensure levels were around what we would expect based on published levels, to say that the absorption was occurring as we would like. So here are our updated summary guidance statements for use of DOACs for venous thromboembolism in patients with obesity. So number one, consistent with the 2016 the guidance recommendations, we say that the use of any DOAC is appropriate for patients up to a BMI of 40 or weight 120 kilos. If a patient is above 40 kilograms per meter squared or a weight greater than 120 kilos, we separate the DOACs individually and suggest that standard doses of rivaroxaban or apixaban are appropriate regardless of high body weight and BMI. We suggest that similarly rivaroxaban and apixaban are appropriate at standard doses for primary prevention regardless of high BMI and weight. We suggest not to use dabigatran-edoxaban or betrixaban in patients with BMI of greater than 40 or weight greater than 120 kilos because of lack of data. We suggest not to regularly follow drug-specific DOAC levels because of the insufficient data to influence management. And we suggest not to use DOAC for treatment or prevention of PE in the acute setting after bariatric surgery. So that is the end of the formal presentation, and now we are going to open it up for discussion.
All right, thank you so much, Karlyn, for a great presentation and for very important work. Tell you what, we have 950 participants. This is a very hot topic, and I have to say that if we knew we were going to have that many participants, Stephan and I would have done something more with our hair. So we want to get started here, and I want to give the opportunity for, first of all, let me remind everyone, and I should have said this at the beginning, if you have questions, please put them in the Q&A box and not in the chat box. So use the Q&A to ask questions. We'll get to as many as we can. We had some that were submitted prior to the meeting as well. At this point, I'd like to hand it over to Stephan to see if he could comment on, if he has any comments on this topic as well.
Well, thank you, Arthur, and thank you, Karlyn, for the presentation. If I may, I would like to make maybe 5 comments and then more general comments. I typically like to give clear guidance as a clinician to patients and to other healthcare providers. This is what should be done. But I do want to highlight that we have really limited data on the very obese patients. The generalized obese patients between 30 and 40, we have no problems with DOAC dosing. But once you get up to the BMI of 50 or 55 or 60 that we see every so often, we don't know how those patients really do. And we cannot be dogmatic with any decision making. So that's number 1 point. Number 2, whenever we use anticoagulants, none of the anticoagulants are really great drugs. Warfarin is difficult in many patients, particularly in the bariatric surgery population. So none of the anticoagulants are really great choices. Low molecular heparin injections or fondaparinux injections in the obese patients, you don't know really how well absorbed it is depending on where they inject. We often don't know, should we use absolute body weight or ideal body weight? Then there are patients with impaired renal function on top of the obesity. So the multifactorial aspect of managing patients is also difficult. So again, one cannot be dogmatic, but we need to keep in mind that blood clots, DVT-PE, are typically multifactorial, and not every patient has the same risk of recurrence and needs the same concern about really having adequate anticoagulation. There's some very prothrombotic, others less prothrombotic. And then the second aspect of anticoagulation, bleeding, is always multifactorial. Has hemorrhoids, has thrombocytopenia, has liver disease. So my typical approach is with DVTMP to think about the risk factors as an ABC, to just be aware it's multifactorial, that we don't focus on just one thing. Similarly, with the bleeding, to list the ABCs of risk of recurrence and then weigh the two things. And then the third aspect is patient preference, obviously, and that needs to be discussed, low molecular weight heparin, injections, the cost of it, etc. So that's my second point. The number two is that none of the anticoagulants are really great choices typically. And number three is the multifactorial aspects. And then fourthly, we are not a one-person decision maker typically. With these patients, the anticoagulation provider, the primary care physician, maybe the anticoagulation clinic is involved. So it needs to, particularly in the severely obese patients, when you make a decision, it's worthwhile to discuss it with the various people involved. Bariatric surgery, to get the bariatric surgeon involved, I find important. And then lastly, this guidance document was put together by 6 individuals who are in the United States and Europe, and it's been a long process, and it has been a lot of fun and has been eye-opening, the discussions between the different people who come from different areas. In this day and age of diversity, I do want to highlight, however, that 5 out of the 6 individuals were males. Karlyn is the only female. These individuals were all from Europe and the US, so we have not included other continents. And then maybe really important, we had not a pharmacist on board, even though we've discussed with some of the PK/PD pharmacists here at UNC, and they've been involved in discussions, but not part of the authorship. So with the future, I think more diversity would be nice. That's what I wanted to say. Thanks very much.
Thank you, Stephan. You brought up exactly the kind of things that I've always thought about with this topic, and I think part of the issue that we've seen, with the initial guidance in 2016 was that it was kind of taken as a line in the sand. It was like this hard stop issue, and I would argue that was kind of never appropriate. That it's multifactorial, as you said. The patient should have some say-so. Should make informed decisions. And a patient with a history of venous thrombosis 5 years ago, that transitioning to a DOAC is not the same as a patient with an acute saddle PE. Those are 2 different patients with 2 different levels of concern. So thank you for that.
And Arthur, I'm going to add to that because it was really interesting. The 2016 document, based on very few data, was more a suggestion, but it triggered, and I like that, it triggered a lot of additional studies and sub-analyses of the existing studies, rather than an adoption of, oh, DOACs are okay to use and everybody who's obese, which one could have argued from the FDA approval. So additional data were created and then allowed this much more data-driven new guidance document, and I like that.
Yeah, congratulations to you both on the work. It's been a long time coming, so thank you. You kind of addressed this stuff, and I'm gonna kick it off with the first question. You've kind of addressed this in your discussion there, but is there an upper end where we can say, yes, we're comfortable with obesity and high BMI, but is there an upper end where you would yourself or Karlyn, either one of you, take a hard stop and say, man, I'm just really not comfortable?
Karlyn, do you want to take a stab at that?
Yeah, I mean, I would say no, at this point. There is not an upper limit that I have a hard and fast. I think the data would suggest that at least the rivaroxaban and apixaban are not impacted by obesity at this point. So, it's been a practice shift for me, and so I can't say that I don't pause, but at this point, there isn't any data that I've seen that would make me concerned, and I do offer it as an option for my patients, regardless of BMI at this point.
So Arthur, I'm going to take a little different stand, simply because in the patients with a BMI above 50, I wonder, how do they respond to the DOACs? So I tend to think about getting a trough level in those patients. We have not included that into the guidance as a document, as a recommendation, a suggestion. And Karlyn said, why not? And I think it shouldn't be in there. But some practicing physicians do think about drug levels every so often. The point is, we don't quite know what to do with it, but I'm looking for subtherapeutic levels. And then people do ask, well, would you get a peak or a trough level? And I don't do peak levels anymore. We used to have them in the 2016 guidance document, but peak levels after oral intake, they can be seen at 2.5 hours, at 4 hours, and some people at 5 or 6 hours. So you don't really know, is it a peak level that you're getting or not? A trough level is always a trough level before the next dose. So I would use a trough level. And then the next question people ask, well, what are expected trough levels? And that's a little bit, there are various data out there, but I tend to go to a publication from Samuelson and Adam Suker from 2017 or so in Circulation, I believe. They have a nice table 1, which has a peak and trough with the different levels. You can criticize some of that, where did they come from, what population, etc., but it gives you a rough idea. And again, one cannot be dogmatic that they need to fall into this, but it gives you a rough idea what are expected levels. We know DOAC levels in people they have a huge spread anyway. And then as Karlyn said, often we don't know, do they correlate with efficacy and safety in the individual patient? So the values are not then dogmatic, this is what we need to do because the level is low or high, but it gives me a little bit more comfort, and whether it's meaningful comfort or not, but it gives me comfort if the level is truly in the expected range.
Thanks so much. I think perhaps it's my turn to take over the question answering. So Karlyn, wonderful presentation. Thank you. And this has been such a great discussion. There are so many excellent questions in the chat box. It's almost challenging to pick which ones we want to address right now. But one of the ones that keeps coming up regularly from attendees is the question about dosing for secondary prevention of VTE, after the initial treatment of 6 or 12 months. And so it sounds as though there's a consideration now with the liberalization of weight for eligibility for DOACs, maybe more so in Karlyn's practice than Stephan's. But can you maybe provide some thoughts or how you approach this issue of dosing when you're considering secondary prevention treatment, and whether or not you routinely dose reduce patients in that setting?
Yeah, thanks for the question. I think this is a tough one because we have very limited studies about the Amplify Extension trial and the Einstein Choice trial. I think we need more data to better understand who this is appropriate to use these reduced doses long term. I do dose reduce in some of my patients, I will say. I have not yet started dose reducing my obese patients, particularly if they're in that BMI above 40, 45 category. I just don't have the comfort yet. I don't think there's, we've tried to look to see if there were data published in this particular population in this longer term secondary prevention, but we couldn't find any. So I at this point, I don't routinely reduce the dose of apixaban or rivaroxaban in my patients with obesity, unless there's some other reason to do so.
And that's an easy question for me, actually. I also do not dose reduce above a BMI. I continue the full dose. The dose reduction, even in the more light patients, I'm not very liberal in giving that to everybody at 6 months. I tend to reserve it for the patients who are elderly, who are fragile, who had low risk for bleeding, who had low body weight, because we know those people have a high risk for bleeding. Keeping in mind that the Einstein Choice trial and the Amplify Extension trials enrolled patients where the physician had equipoise, does this patient really need to be on anticoagulation or not? If I have a patient with an unprovoked DVT or PE who has, by all guidelines, including the recent ASH guideline from last year, who has an indication for long-term anticoagulation, I tend to use full dose anticoagulation unless the criteria fit that I just mentioned a second ago. However, and I need to say that when they looked at Amplify Extension and Einstein Choice, the majority of patients were people with unprovoked VTE. So you could certainly argue, well, even in the normal weight people, the reduction is appropriate. And then you could say, well, maybe in the obese patients as well. But my answer is BMI above 40, weight more than 20 kilos, I continue the full dose anticoagulant at this point.
At risk of belaboring this topic, this is something that comes up a lot, and you know, we're kind of stuck with it's technically off-label in the U.S. not to. In Europe, they actually use the equipoise language in the label. In the U.S., they do not. The recently published, hot off the presses, CHEST guidelines recommend doing it in most patients. They do have some suggestions of who you may not consider doing it in. And to your point, if you look at, yes, there was equipoise in the extension trials, but if you actually pull the tables of the patients that were in there and you apply how we think now, you realize that there's a lot of folks that there should not have been equipoise and whether or not they continue therapy. So my stance on this is you don't get a lot from dose reducing. You actually don't even save on major bleeding. You save on minor and clinically relevant non-major bleeding. Reasonable to dose reduce if the patients look like the patients in the trial. So when you if you then apply, well, are they super duper high risk for thrombotic risk? Maybe different than trial patients, and are they at risk of underexposure from the drug, perhaps like in the obese setting, then I say they don't look like the patients in the trial, and therefore, and you don't get much from dose reducing anyway. So in those cases, I tend to maintain full dose. So not to belabor the issue, but I think there's a lot of discussion about this and a lot of opinions on the table. So
topic for another guidance document.
Certainly, I think there's a lot more we can all agree that needs to be studied. A question that's come up repeatedly in the chat box is which DOAC do we choose? We know that there was kind of a highlight about rivaroxaban, but now with this new evidence surrounding Eliquis, for the two of you, which do you typically lean toward? Is there certain patients that you would choose rivaroxaban versus Eliquis or apixaban? Or how do you make that selection?
Stephan, you want me to go?
Yes.
I think when we wrote the guidance document, there were many more data, many more studies publishing data for rivaroxaban, and that's why we made the recommendation we did. I think there have been more publications, more studies showing that apixaban is as safe and effective. I think they've never been studied head to head. If all the things being equal, I tend to recommend apixaban because I think there may be a slightly lower bleeding risk, but a lot plays into it, including insurance coverage. Can a patient adhere to twice a day regimen, or if they're going to miss one of their doses majority of the days anyway, then it's much better for them to be on a daily dose. Any bleeding complications, all of that plays into the decision. So I don't have one strong recommendation over another at this point in my practice.
And we're talking about the non-bariatric surgery patients. So my tendency is to use rivaroxaban because I still have the impression there are more data on that available. But if somebody is on apixaban, I don't switch patients over. And then the same thought process applies as in other patients, and Karlyn mentioned the cost, the comfort of once versus twice daily, but also the bleeding risk, particularly in women with menstrual bleeds. Maybe the apixaban is, maybe it's safer than rivaroxaban. So it all factors together. But my first thought is rivaroxaban in the very obese patient with then some modifications.
thank you. And that actually transitions us to quite a few questions about the bariatric surgery, one of which you mentioned rivaroxaban preference. Is that because of the more proximal absorption that you see with rivaroxaban as compared to apixaban? And are those, is that assumption of where it's absorbed tied to hard data?
Karlyn, I go second.
Take a second. I do, yeah. Again, I don't often use the DOACs routinely in my patients who are post-bariatric surgery, and if I do, usually they're already on one, to be honest, and so I just keep going with whatever they're on, and I tend to check DOAC level in my patients who are post-bariatric surgery, especially if they're recent. If they're 5-10 years out, I'm not so diligent about it, but I do like to use the levels in those patients to make sure that they're absorbing and reaching what would be expected levels. But I can't say that I have a strong preference for one versus the other in my post-bariatric surgery patients.
So I echo what Karlyn says. As a hematologist, I typically see the patients either before bariatric surgery, and then the surgeon asks me in the consultation, what do we do after surgery? And then I recommend what we have in the guidance document for the first several weeks. And it's not just 4 weeks exactly, it may be 2 months or 3 months, depending on how the patient does, to use a parenteral anticoagulant. And I feel strongly about that one. And then the other group of patients that we see, as Karlyn also highlights, they are already on a DOAC. And I also don't change them over if they've done fine for the last 3 months after bariatric surgery, but I do get a trough level to see where we stand with it. And if I were to say which one would I use after bariatric surgery, if a DOAC needs to be used, and these are the patients with a high warfarin hate factor. So they've been on warfarin or on low-molecular heparin, and they hate to be on it because of the injections or the fluctuating INRs, the diet, etc. Then my preference would be after bariatric surgery to use apixaban, because there's some suggestion that it's also absorbed in the more distal intestine, whereas rivaroxaban is clearly absorbed in the distal stomach, the duodenum, and the jejunum, and that's all disturbed after bariatric surgery. Now, apixaban is also absorbed, all the anticoagulants, in the very proximal intestine. But as I mentioned, apixaban is also, or it appears to be somewhat in the more distal intestine, so maybe a somewhat more reliable drug, but I would do a trough level.
Thank you for that. So maybe we'll stick with the same theme of discussing bariatric surgery, the setting of bariatric surgery a little bit further, and appreciating, of course, that there's even there are fewer data for DOACs in this setting. Just one of the questions that came up in the chat was around the timing of DOAC initiation. If there was an opportunity to treat a patient who'd had bariatric surgery, is there evidence for recommending the DOAC after 4 weeks after bariatric surgery, or what type of time frame is reasonable? And then maybe follow up with that, is there maybe some consideration given to the timing of initiation of DOAC relative to the VTE? So, are you managing patients differently with acute VTE perhaps versus remote VTE? So those are maybe two different but related questions.
And Deb, that's a really good point. I mean, if you have an acute DVT-LP, you want to really make sure that you get good anticoagulation, whereas if the DVT-LP was a year ago or 2 years ago, then subtherapeutic levels for some period of time do not pose a huge risk for recurrent clots. So that does factor into it. Regarding the timing after bariatric surgery, I mean, as a hematologist, I don't see these patients over time after bariatric surgery, but Karlyn and I and the group have discussed it extensively and read about it, and also published a specific paper on bariatric surgery. I mean, the weight loss differs from patient to patient. The adjustment of the intestinal tract to the surgery varies from patient to patient. The oral intake, in some people they take small, frequent meals, others have a completely different oral intake. And then the weight, by when does it stabilize or does it continue to go down? There's so much inter-individual variability that I couldn't say at this point it's appropriate to start the DOAC. So I would not say 4 weeks. We put that into our document, at least 4 weeks they should be on parenteral. But some of us, including me, thought, well, maybe we should put in there 3 months because it takes a while to adjust to the bariatric surgery. Again, we cannot be dogmatic. It's an individual decision.
And just to jump in here real quick on that, what about the different types of bariatric surgery? So These things that go from gastric bands to gastric sleeves to full on Roux-en-Y's. What are your thoughts on the I know certainly with Roux-en-Y you're considering, I'm really, really worried about this, but can you talk about perhaps some of the other, what I might consider less invasive bariatric approaches?
And Karlyn, if you allow me to just show this AC Forum document that was mentioned by Liz Goldstein earlier. It's really this document on the web of the AC Forum, which is a summary of the use of direct oral anticoagulants after bariatric surgery. And it lists the individual surgeries with images and which of the drugs might be preferred. And I think it's a good document. Now, the document states that in gastric banding and in partial sleeve gastrectomy, maybe apixaban would be the preferred drug choice. And maybe it is indeed, because maybe it is, but I'm still not sure that it is. The DOACs in general, after bariatric surgery, I'm a little concerned about them, particularly in the first few months when the patient is adjusting to the surgery. But if a drug were to be preferred, then apixaban might be the one in those two surgeries.
Thanks for that info. From a practical standpoint, a lot of our membership are people who work in anticoagulation clinics, and they're kind of in the trenches and they're trying to figure out, where do we get these anti-10A levels drawn? How do we go about that? I know in my practice, we have patients go to the lab and then it's a send out to like a LabCorp or a Quest or something like that, and we get the levels back. Do you guys have any other strategies? Do you do any in-house testing with these anti-10A levels at your facilities, or how is that handled? Just so our membership can and our attendees can find out where's the best place to get this done and how do we facilitate it?
We have an in-house assay where we run rivaroxaban and apixaban anti-10As. So that's how I get them done. But I know that you can send them out to LabCorp and maybe Quest. The problem, obviously, as you all know, if you send it out, you don't get a level for a week, 2 weeks. So it's less helpful in the acute setting. So you're kind of limited by what resources you have. But I think I'm fortunate in that I have one in-house.
I think it depends on the healthcare system. And I know that LabCorp has a quick turnaround. At least when we send tests to LabCorp, we get it back within 3 or 4 days. I have to say, though, typically these indications are not that we need a level immediately back. Is the patient's doing okay? And we wonder, is the patient absorbing this appropriately? And we get a trough level. To wait for 3 or 4 or 5 days typically does not make a treatment difference. So I don't think there is a loss if it does not get done in-house.
I find that, I'm sorry, go ahead, Deb.
I just wanted to ask a quick follow-up question. And I know, Stephan, you mentioned before measuring trough anti-10A levels relatively frequently. Do you do, just for the benefit of those on the audience, if they are going to order a test, is it one test? Is it, do you repeat that? We know that there's kind of a lot of inter and intra-individual variability just in the test results. So, when are you satisfied that your patient is probably has levels that are, within expected on therapy range?
Yeah, Deb, that's a good question. I typically would only do one level. And I do appreciate that there's a lot of variability in one individual if you test over time. And you also wonder about compliance of the patient taking the medication. It's a messy field, I must say, and that's why I would not overvalue the value that you get. But if I get a 0 level or less, whatever the test's lower limit of detection is, and I know that with a LabCorp, the lower level of detection is typically less than 10 nanogram per ml. And with some other labs, it's less than 30. So it really depends on what you get. But if the value is really undetectable, and I have the impression the patient has been taking it, that's the time when I would say, well, maybe we should be switching to a different anticoagulant, be it warfarin, and that typically would be the next choice. but I've also had lowish values and then just said, oh, I'm not sure we should act on that because the patient doesn't want to switch over to warfarin. I think the level for me is mostly helpful. I'm hoping it's in the expected range, and then I feel more comfortable and kind of reassure the patient also, look, we have a good value. I'm not concerned about you.
I think it's interesting. Maybe we should do a study on this. I believe that the likelihood of recommending a DOAC level is directly proportional to your ability to get one. So I think it's actually interesting when you talk to different providers about whether or not they get those. I want to switch gears just a little bit here because we have a lot of questions about this. Can we extrapolate this to AFib? And to lead off that question, I will say these are different populations. My stance as a simple-minded guy is that if you can use a DOAC in a patient with an active hot clot, you can use a DOAC in a patient with risk of developing a clot with a relatively low annualized risk of developing clot. And I would argue that most of the data out there, if you were to do a research, if you were to do a lit search, you would find that most of the talk in the field has been surrounding the AFib population when trying to answer this question. This guideline, though, is specific to VTE. So I'll kick that over to you, Karlyn, if you want to just touch on that.
Yes, I can take that one. I agree with you that they're different populations and they come with different risks. We chose to separate out because most of us, or all of us, are clot treaters. We're VTE as hematologists. And so we don't treat patients with AFib. We're not managing their anticoagulants and wanted to update the guidance statements expeditiously, and then certainly there is a lot more data for AFib. So in what I have seen and what I have looked at, it does look like the DOACs are safe and effective in patients with AFib as well. I think there have been a couple meta-analyses published recently about observational studies that similarly show support for using the DOACs in the AFib population, but we did not do a thorough literature review and look at the data behind that, and that's why we didn't include it in our guidance statements.
And I echo that, and as a hematologist, I'm not involved with AFib decisions anymore, and the population is different. They're often elderly, higher risk for bleeding, etc. But it looks like the DOACs in the obese AFib population are at least as good as warfarin. But I agree, we didn't feel comfortable that we knew the literature well enough and didn't feel we should embark on a field that we don't do clinically and give recommendations. I always hate to give recommendations from the office to clinicians who are treating patients. So we didn't feel that was appropriate.
Yeah, I agree. I think actually the question in the VTE population has been the more important question to answer. And so I'm happy to have guidance there. All right, Deb, you have a question for us?
Sure. It's I have a question about, Stephan mentioned the importance of, shared decision making, particularly in areas of uncertainty. And I'm wondering, it might be of benefit for the participants on the call, just if you shared a few thoughts about how you approach this with patients. So, recognizing that there is uncertainty here, making a decision about the optimal anticoagulant treatment for them. I don't know if there's some way that you do that in your clinical practice that you find very helpful. Maybe we'll start with Karlyn.
Sure. In the past, when before we updated these guidance statements, even beforehand, I would tell my patients, there is not a lot of data in patients of your weight. There weren't as many patients in your weight in the randomized trials. We don't know specifically whether they perform as well. But in the last year or year and a half, when there were more studies coming out, I would say we're getting more data. People are publishing that they have their patients on these drugs and they seem to be safe and effective. Particularly if a patient felt very strongly about being on a DOAC compared with warfarin, I would say we don't have as much data, but at this point, I'm comfortable with that as well, recognizing that we don't have as much. I think now I don't bring it up as much with them if I have them on rivaroxaban or apixaban, or I'll say, we have shifted our practice. We now recognize that these are effective and safe based on the data that's been published. So it's shared decision in that tell them what is out there, but also what I, as a treating clinician, how I interpret the data that's available, and whether I think it's acceptable for them to be on this medication. That's how I typically approach it. Stephan, how do you do it?
I agree with that, and I have increasingly I feel comfortable telling patients when we don't know really what's the right thing to do. I tell them we don't really know what's the right thing to do. And yes, I do say people of body mass index more than 50 or 55 or 60, we don't have solid data. I find it helpful to have this ISTH guidance document now that we can say, well, the more formal recommendation after literature review says this and that we can use the DOACs, and then I do the trough level. So I find the document, even though I'm a co-author on it, I find it helpful in my clinical practice to say people have thought about this and reviewed the literature in detail. And Arthur and Deb and Andrea, maybe this is also an appropriate time when Karlyn mentions the shared decision-making, and I mentioned a little earlier the warfarin hate factor or the rivaroxaban hate factor or apixaban hate factor, and some of you have heard me mention that before. I've used this for a number of years, and it's my assessment of patient preference that I ask them on a scale from 0 to 10, how much do you hate to be on warfarin? 0 means it's just a pill, I don't mind. 10 means I hate it so much I need to come off, and then they spill out. It's because of the diet interactions or the warfarin, the monitoring. And with a direct oral anticoagulants, it's specifically what's the cost for you, what's the copay, and that helps with the decision making as well, which drug to use then. So that's a warfarin hate factor and the DOAC hate factor.
I think we need to also consider the clinician's warfarin hate factor. I've made a career on warfarin for 20 years. I mean, I had hair when I started managing warfarin, and I now hate warfarin. And if you think about drugs, warfarin is a weird drug, and it doesn't make sense, and it doesn't behave itself. But we had to get new drugs that did behave themselves to get that perspective. So
I think we're getting close to the end, but we'll kind of wrap up with one more question. There's been a few folks who have asked in the chat box if there's other sort of intestinal surgeries that we should consider limiting DOACs. I know personally in my own practice, I had a patient who's had multiple intestinal surgeries, and she was on warfarin. It wasn't working well. So we switched her over to rivaroxaban, and I got an anti-10A level, and her levels were undetectable. And she even told me, she's like, Andrea, through my colostomy, I can see some of my pills coming out whole, which, yeah, so she's not absorbing it. So we switched her back over to warfarin. But are there other intestinal surgeries or things like Whipple procedures or any other surgeries where we should consider the absorption factor?
Karlyn, you want to give that a shot?
I mean, I just try to pay attention to any intestinal or gastric surgery and say it's the same sort of mechanism that we worry about. Are they not absorbing? And so if you've gotten rid of some part of your absorptive surface, then I think we need to think about it. And that would be a patient that I would either worry about or at least check a level similar to any bypass surgery.
And the summary is that all anticoagulants, including warfarin, are mostly absorbed in the proximal intestine. So anything that involves the duodenum, the jejunum, and maybe the ileum, less so the ileum, barely the colon. Any of the more proximal intestinal surgeries can be a problem with the DOACs. And clinically, a problem is that patients often don't know what part of the intestine was removed and how much was removed. Was it the large, the small intestine, 6 inches, 30 inches? that can be very difficult.
Well, thank you so much for this incredible presentation. We had almost 1,000 people on, which shows what an important topic this is. So I want to thank our presenters, Dr. Karlyn Martin and Dr. Stephan Moll. Thank you so much for all your work and providing this great guidance. And to Dr. Arthur Allen, Deb Siegal, and Andrea Van Beek, our amazing multidisciplinary AC Forum webinar team. Thank you so much for moderating all these questions. I think we had over 80 or 90 questions come in. This presentation has been recorded and will be up on our website, acforum.org, in the next few days, along with the slides. It also is accredited for credit. So this is the link of how to claim credit. If you enjoyed this webinar, please join us at our national conference. We have transitioned to virtual, and it is going to be the same feeling as this webinar. So there's going to be a presentation and then live panel sessions handling the Q&A. So if you join us live, you'll be able to participate in the panel discussion. Again, I just wanted to point to this rapid resource that's available in our resource center that was just updated. We also have a new online literature update, which is curated anticoagulation related literature. It's updated twice a month. It highlights the most important articles that you need to see, including the abstracts. And you can find all of this information, the rapid resources, the literature update, and a newsletter summarizing the most important literature in our Anticoagulation Center's Resource Center. Sorry, Centers of Excellence Resource Center. And with that, I'd like to thank you all for joining us and to thank our sponsors who help support this program. Have a great day. Thank you, everyone.